monoamine oxidase inhibitors, MAO. This is an enzyme found in nerve and other tissues such as gut and liver. This functions as a safety valve to deaminate and activate any excess neurotransmitters. It will metabolize them. The MAO inhibitors will irreversibly or reversibly inactivate the enzyme, so the neurotransmitter will escape this metabolism and will be available in more quantity in the synaptic cleft. The four currently available are phenelzine, trenylcypromine, isocarboxazid, seleglin. Seleglin is used to treat for Parkinson's disease also, we have seen previously. It is the only antidepressant available as transdermal delivery system. Okay, seleglin. Now, mechanism of action, as you know, they inhibit the enzyme such as phenelzine. This is form stable complexes with the enzyme and cause irreversible inactivation, and it will result in the increase in stores of norepinephrine, serotonin and dopamine within the synaptic cleft. The drugs will inhibit not only MAO in the brain but also in the liver and gut. Therefore, they have high incidence of drug-drug interactions, drug-food interactions as well. Seleglin administered at transdermal patch will have reduced this gut and hepatic metabolism as well as interactions. Now, normal monoamine oxidase, what does it do? The neurotransmitters are in the synaptic cleft. The synaptic cleft releases them. Some of them are released and some of them undergo degradation to inactive metabolites. The quantity available will go and bind to the receptors and produce a response. Now, when we take the drugs, monoamine oxidase inhibitors, they will inhibit this enzyme and inhibit this process of converting to inactive form. Therefore, more amount of the neurotransmitter will be available in synaptic cleft and will bind, more of them will bind and produce the effect. Now, their actions. They require several days of treatment like that of other SSRI, SNRI and TCA, several weeks. Seleglin and transcyclopromine, they have amphetamine-like stimulant activity and produce agitation or insomnia. Therapeutic uses: indicated for depressed patients and who are unresponsive for other drugs, because it have many drug-drug and drug-food interactions, so it is the last line of treatment. Now, 2 weeks of delay must be allowed after termination of therapy. Initiation from any other class, so we need a 2 weeks delay because they are hepatically metabolized and excreted rapidly in urine, and they are absorbed well after oral administration. They are irreversibly blocking. Now, adverse effect, they have many. That's why they due to drug-food, drug-drug interactions. Tyramine, this is very important. It is contained in foods such as aged cheese, meats, liver, pickles, smoked fish, red mines. Is normally inactivated by this enzyme, monoamine oxidase. When this enzyme is not present, it means these are not inactivated. This tyramine is not inactivated. So, individuals who receive this are unable to degrade tyramine. Tyramine then will cause large amounts of stored catecholamines from nerve terminals, resulting in hypertensive crisis. And signs and symptoms will include headaches, stiff neck, tachycardia, nausea, hypertension, cardiac arrhythmia, seizures, and possibly stroke. Patients should be consulted to avoid tyramine containing foods. Other are adverse effect: drowsiness, orthostatic hypertension, blurred vision, dry mouth, and constipation. SSRI should not be co-administered due to the risk of serotonin syndrome. Both require a washout of period of 2 weeks at least when you have to administer the other class. Now, here this is some adverse effect related. First, selective serotonin reuptake. SSRI, citalopram, GI distress, escitalopram, fluoxetine, fluvoxamine, paroxetine, sertraline. These all have GI distress. Fluoxetine also shows insomnia, sertraline insomnia, fluvoxamine and paroxetine, they are sedating. For SNRI, none of them is sedating, none of them produces insomnia, but they all cause GI distress. Atypical antidepressant bupropion will cause insomnia. Mirtazapine and nefazodone will cause sedating. Trazodone, they are sedating. Mirtazapine is also increases weight gain. Nefazodone, velazodone, and vortioxetine, they will cause GI distress. Now TCA, you see there are many. Amitriptyline, amoxapine, mostly all of them are sedating, and none of them causes insomnia because all of them are sedating, and many of them cause GI distress. Now monoamine oxidase inhibitor, phenelzine, it will cause orthostatic hypotension. Siliglene, insomnia. Transcyclomine, insomnia. Transcyclomine will also cause orthostatic hypotension. None of them will cause weight gain. Weight gain is mostly related to TCAs. These are the side effects.